Picture this. A woman is 68 years old, a retired nurse, sharp, capable, the kind of woman who still hosts Sunday dinner for 12 people and remembers everyone's food allergies. Her daughter convinces her to finally get a full workup, just to have a baseline. Mom feels completely fine. No chest pain, no shortness of breath, no symptoms of any kind. She walks into that appointment healthy. 8 months later, she is on her third follow-up procedure. She has a stent in her heart for a blockage that, according to 2 separate cardiologists she consulted afterward, was stable, slow-moving, and would never have caused her a single problem. She now takes 4 medications she did not take before. She is tired in a way she was not before, and the Sunday dinners have stopped, not because she cannot cook, but because the confidence that her body was her own has quietly left the building. Her name is Patricia, and when I sat with her 18 months later, she said something I have never forgotten. I went in for a checkup. I came out with a medical career. That sentence has stayed with me for years, because Patricia is not an edge case. Patricia is a pattern, and that pattern has a name in the medical literature. It has a mechanism, and once you understand it, you will never sit in a doctor's office the same way again. My name is Dr. Emily Johnson. I am a cardiologist with 32 years of watching what happens to adults over 60, not just at the cellular level, but at the life level. What happens to their independence, their confidence, their quality of the years they actually have? And what I have seen repeatedly across 3 decades is this. The medical system was built for sick people. When you run a well person through that same system after 65, the results are not always what anyone intended. That is what today is about. If this is your first time here, hit subscribe right now. Every week, I bring you the conversations that do not happen in the 15-minute appointment, the ones that require honesty, time, and 32 years of watching what actually happens to real people. Subscribe before we go further. Before the 5 checkups, I need to give you one concept. Without it, everything else I say today is just noise. After 65, 3 things change the risk math completely. First, many conditions that routine screening finds in older adults are biologically quiet. They grow slowly, produce no symptoms, and are not on a trajectory to hurt you. But once a result appears on a report, medicine does not have a leave it alone button. It has a treat it button, and that button gets pressed. Second, your body's tolerance for intervention is not what it was at 50. A procedure a 55-year-old recovers from in 10 days can mean 3 months of complications and lost independence for someone who is 72. Third, hold this through every item on this list. There is something called the cascade effect. One routine test finds a small abnormality. That abnormality triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. A person who walked in feeling completely fine is now managing a medical situation they did not have before they said yes to the first test. The cascade does not begin with the surgery. It begins with the word routine. Drop your age and city in the comments right now. I read every one. Checkup number 5, routine PSA, prostate screening after 70 in asymptomatic men. I am not saying prostate cancer is not real. I am saying this. For men over 70 with no symptoms and no family history, the data tells a story most men have never been told. A PSA test can detect a prostate cancer that is biologically barely moving. A slow-growing tumor that left alone would never spread, never cause a symptom, and in a 71-year-old man would almost certainly never shorten his life. He would live with it, not from it. But the moment that result comes back elevated, medicine does not wait. Biopsies are ordered, specialists are referred, and treatment for low-grade prostate cancer can mean radiation, hormone therapy, or surgery, each carrying real risks to continence, energy, sexual function, and the texture of daily life. Harold is 73, a retired football coach from Birmingham, Alabama, fit, active, no symptoms of any kind. A routine PSA came back slightly elevated. A biopsy confirmed low-grade, slow-growing cancer, Gleason score 6, about as slow-moving as prostate cancer gets. His urologist recommended radiation. Harold trusted it. Within a year, he was dealing with chronic fatigue that ended his morning walks and urinary urgency that dictated where he could go. Coach spent 40 years telling boys to play through discomfort. Nobody told me the doctor's office would be the thing that finally sat me down. If you are 70 plus, asymptomatic, and average risk, the question is not, do we screen? The question is, what would we actually do if we found something? And is that treatment genuinely better for my life than watching it carefully? Checkup number 4, routine bone density DEXA scanning paired with automatic long-term medication. There is a difference between questioning a test and questioning the automatic pipeline that follows it. When a DEXA scan shows low bone density, many physicians move immediately to bisphosphonates, Fosamax, Boniva, Actonel. The message is low bone density equals medication. Medication equals protection. Here's what that message quietly leaves out. Long-term bisphosphonate use beyond 5 years has been associated with atypical femoral fractures, stress fractures in the thigh bone, the very bone you were taking the medication to protect. There is also osteonecrosis of the jaw, triggered by the same medication meant to strengthen your skeleton. Meanwhile, the single most effective intervention for reducing fractures in adults over 65 is not a pill. It is fall prevention, balance training, removing trip hazards, installing grab bars, reviewing medications that cause dizziness. Studies on Tai Chi show it reduces fall risk by close to 50%. These approaches lower your actual fracture risk more meaningfully than most prescriptions, with 0 side effects. Eleanor is 74, a retired librarian from Savannah, Georgia. Her DEXA showed low bone density. Her doctor prescribed a bisphosphonate that same afternoon. Eleanor came to me 2 years later with a deep aching in her thigh, an early atypical stress fracture. She had never fallen. She had no fracture history. The medication meant to prevent a fracture was what her bone was quietly reacting to. I trusted the pill more than I trusted my own 2 feet. Turns out my feet deserved more credit. Before agreeing to automatic medication, ask, what is my actual fracture risk based on my full profile, not just the scan? And can we compare medication against a structured fall prevention program? Checkup number 3, routine cardiac stress testing without symptoms. This is the one that surprises people most because it sounds so responsible. Your doctor says, "You are 67, let us just make sure your heart is doing well." What could possibly be wrong with that? Here is what almost no one says in the appointment room. Cardiac stress tests in people without symptoms have false positive rates that can reach 40% in certain populations. That means nearly half the cases flag an abnormality when your heart is actually fine. But medicine cannot shrug at an abnormal result. That false alarm sends you to a cardiac catheterization, a thin tube threaded through your blood vessels directly into your heart, carrying real risks of bleeding, vessel damage, and arrhythmia. And if it finds a partial blockage, extremely common in adults over 65, you may receive a stent. Here is what I need you to hear as a cardiologist with 32 years of watching this play out. The ischemia trial, one of the largest of its kind, found that stenting in stable coronary artery disease did not reduce heart attacks or extend life compared to medication and lifestyle alone. The stent did not outperform a 30-minute daily walk, but it carried all the procedural risk and often years of mandatory blood thinners. Douglas is 69, a retired electrician from Columbus, Ohio. No symptoms. A routine stress test flagged an abnormality. Catheterization followed. A stent was placed. He spent 2 years on blood thinners. A single fall could have become a life-threatening bleed. He gave up woodworking. He stopped hiking, not because his heart told him to, but because the treatment of a stable condition rewrote the terms of his daily existence. I went in to make sure I was fine. I came out with a new set of rules for how to live. Type the number 3 in the comments if you are following along. If you have no symptoms, the conversation should not be about stress testing. It should be about blood pressure, cholesterol, blood sugar, sleep, and activity. That is where the real cardiac gains live, and none of them require a catheterization to access. Checkup number 2, routine carotid artery ultrasound in asymptomatic patients. Almost nobody is talking about this one, and that silence may be one of the most consequential oversights in routine senior care today. A carotid ultrasound looks at the blood vessels in your neck that carry blood to your brain. Find a blockage, surgically clear it out, the logic sounds airtight. The reality is far more dangerous. The surgical procedure to treat a carotid blockage carries a 2 to 3% risk of causing a stroke during or immediately after the surgery. The United States Preventive Services Task Force explicitly recommends against routine carotid ultrasound in adults with no symptoms. Their reasoning? The risk of intervention outweighs the likely benefit. A large portion of adults over 65 have some narrowing in their carotid arteries, stable, silent, not causing problems. When you screen routinely, you find it. And the surgery to clear a blockage that was never causing symptoms can dislodge a piece of plaque that travels directly to the brain. The intervention causes the exact outcome it was designed to prevent. Vincent is 71, a retired postal worker from Memphis, Tennessee. No symptoms of any kind. A routine workup found moderate carotid narrowing. Surgery was recommended. Vincent asked me for a second opinion, the single best decision he made. His blood pressure was controlled, his medications were appropriate, and there was no justification for surgery. 4 years later, he walks 2 miles every morning. That narrowing remains exactly where it was, stable, silent, not writing the story of his health. If you have no neurological symptoms, your energy belongs to the actual stroke drivers: blood pressure, blood sugar, atrial fibrillation, and staying active. If you do experience sudden vision changes, facial drooping, arm weakness, or brief confusion, even briefly, even if it resolves, get evaluated immediately. That is not routine screening. That is your body sending an urgent signal. Checkup number 1, routine colonoscopy after age 75 in low-risk asymptomatic adults. This is the one most people have never heard challenged. The United States Preventive Services Task Force explicitly recommends against routine colonoscopy for average-risk adults over 75. The risks begin to outweigh the rewards in ways that become very concrete when you understand what can go wrong. Bowel perforation occurs in approximately 1 in every 500 colonoscopies. In a younger adult, that is a manageable complication. In a 77-year-old, it can mean emergency surgery and a recovery that permanently changes independence. The bowel prep itself can cause dangerous dehydration, electrolyte imbalances, and cardiac stress in older adults. And through the longevity lens, the colon cancers most likely found in asymptomatic adults over 75 grow slowly enough that in many cases they would never cause harm within that person's remaining lifetime. Margaret is 77, a retired school teacher from rural Kentucky. 2 prior colonoscopies, both completely clean. No family history, no symptoms. Her new doctor said she was due for another one. Margaret trusted the recommendation and began the prep at home. By morning, she was confused, too weak to stand. Her daughter drove her to the emergency room before she ever reached the procedure. Electrolytes critically low, heart under strain. She spent 6 days in the hospital. She never had the colonoscopy. I was perfectly healthy until I tried to prove I was perfectly healthy. That does not make any sense, and it is exactly what happened to me. Ask your doctor about non-invasive stool-based testing, Cologuard, or an annual FIT test. These flag genuine warning signs without procedural risk. If you have symptoms, blood in your stool, unexplained bowel changes, persistent abdominal pain, get evaluated regardless of age. Symptoms change everything. The 5 questions. Every time a doctor recommends a screening test and you are over 65 and feeling well, have these ready. Write them down. Put them in your phone right now. Question 1. What is the false positive rate of this test in people my age? Question 2. If this test finds something, what are the realistic treatment options for someone my age, and then what? Question 3. What is the procedural risk of the treatment we would most likely pursue? Question 4. What happens if we monitor this instead of treating it immediately? Question 5. What is the most effective, non-invasive approach for this condition? Any physician genuinely in your corner will welcome those questions. If a doctor makes you feel difficult for asking them, that is important information about whether that doctor is the right fit for you. Before your next appointment, write those 5 questions on a note card or open your Notes app right now and put them there. You may only need 1, but having them changes how you walk into that room. And how you walk into that room changes what happens to your health. There is someone in your life, a spouse, a sibling, an adult child, who needs to hear this before their next annual physical. You do not have to explain it. Just send them this video. If this changed how you think about routine care after 65, subscribe to this channel. Every week, I bring you what 32 years in cardiology taught me, the information that requires more than a 15-minute appointment to deliver. Next week, I am covering the medications routinely prescribed to adults over 65 that carry a completely different risk profile at that age than they do at 50. If you are on more than 2 daily medications, that video was made for you. Leave a comment below. Have you ever had a routine test lead somewhere you did not expect? Your story may be exactly what someone else needs to read before they walk into their next appointment. Take care of yourselves. I will see you next week.